Okay, thank you very much for this very kind introduction. It's a great pleasure to be in Israel, where I came many times in the past, and it is always I'm always happy to be back in this holy land. And it will be I will be very happy to share my experience of minimally invasive approach. And as you see on this slide, the main reason why we do minimally invasive approach and why many surgeons accept this technique is the aesthetic. But the aesthetic is not the only reason. And for instance, you have here of what we did in the past when we were facing such patient who had a breast cancer with a radiotherapy. And here we were afraid to have healing problem here, and we tried to avoid the sternotomy by this incision, which is not too close to this radiotherapy. In this situation, it would be much easier and much efficient to do today through minimally invasive approach. So the indication is not the aesthetic, even if the aesthetic is the most obvious way to assess it. Here you see another reason why we prefer minimally invasive approach. It's just because if you do a sternotomy, the approach to the mitral is not the direct one. While when you do the minimally invasive approach, you have a direct view. And if you introduce the video inside the ventricle, you see how clearly you can assess the papillary muscles and you can increase the quality of the repair you are going to do on the mitral valve insufficiency, for instance. And you never have such look on the papillary muscle when you do a sternotomy. So I think after you are able to deal with those new instrumentation, you have done many cases, you can do and manage more efficiently any technique of repair of the mitral valve. Of course, we have to be one, and the reputation of this approach is to be more complex, more risky, and expensive. And for instance, this is one paper of one of the early pioneers, Friedrich Mohr from Leipzig, who published below 2000 his first 51 patients. And we have to be very happy that a colleague was able to publish so awful results, because to have 10% of mortality rate in such patient, it's almost unacceptable. And we can understand why at the beginning this technique had a bad reputation. And moreover, the increased cost is around 4,000 euros. And now I would like to demonstrate you that today we can have this new approach with a cheap technique, safe, simple, and reproducible. This is the goal of this presentation. Of course, this has been my learning curve, and the first step is to be very confident in the way to deal with the extracorporeal circulation through a femoral access. We can do it with a small incision. You see the artery, you see the vein here, where we can introduce our cannulae. We can also we have to use new instrumentation in order to be more efficient, and we have designed new instruments which are very efficient, particularly this retractor, which allow a good approach of the mitral valve. And here, the next step has been the use of the cross clamp type. The cross clamp. The cross clamp is introduced here in the fifth intercostal space, and it avoids the necessity to use the endoclamp, which is more risky and more expensive. And by doing so, we have increased the safety of this technique. And as you see, this clamp is at the bottom of the field, and inside the chest, this clamp push the lung behind, so it increases also the quality of the exposition of the mitral valve. And here you see how we introduce the clamp and how well the exposure of the left atrial appendage, and you have the pulmonary artery behind the aorta. So we have a very nice control, and we never had any problem with this kind of clamping. And then when you have progressively built this learning curve, you can use what we call the soft tissue And if you use the soft tissue without any rigid retractor, this is the time when you can say you do really minimally invasive approach. And there are many surgeons who try to do minimally invasive approach, but they do some small thoracotomy and they use rigid retractors. And this is why they increase the pain, why you may have more bleeding and more complication due to the approach. And if you want to speak about minimally invasive approach, strictly speaking, you have to avoid any other retractor, and the incision should be no more than 5 centimeters. And again, now I have in my experience more than 700 patients, mainly females at the beginning, but now all the patients, and it's our routine practice. And you see here, this is the incision below the nipple. You here can see the place where I introduced the Chitwood clamp. Here is the place for the video thoracoscope, and here is the place for the mitral valve retractor. Here you see the introduction of the jugular cannulation, which is today no more necessary. And at the beginning, we had the more suitable patient, but today you see that the youngest patient was 15. He was an endocarditis. And here is the oldest patient, 92. So you see that we have any range of age, any range of weight together. Here you see this incision. It's just the size of the nipple. This patient had a small myxomatous tumor. And here the technique is simple. So you need only a very small incision. We don't have to introduce a valve. We don't have to introduce a wing. So the incision can be very small. 2 centimeters is enough in such situation. And when we increase our confidence in the technique, you see indication you didn't imagine before. And for instance, who would like to have a sternotomy here when you have an infected laparotomy, or here when you have a tracheostomy? So here, in this situation, the use of a minimally invasive approach is very efficient and particularly logical. Those patients are very sick patients. Mainly it was endocarditis. They were in reanimation for many days or weeks. And of course, in such situation, these are patients who are difficult to take in charge. Here again, another patient who committed suicide by burning herself. Here also an indication or in a patient who had osteogenesis imperfecta. She had at least not far from 100 fracture in his life. She was 92 centimeters and his weight was around 30 kilograms. So as you see, when you see this sternum, you can imagine that the surgeon is not very happy to have to approach the heart through the sternum. And again, in this situation, you see how reluctant the surgeon were, because you see the enlarged heart, and this lady who was unable to walk was dyspneic at rest. And in this situation, it was elegant to use a very small incision. We didn't spare the ribs, and I was able to repair the valve through this small approach. Excuse me for the so here you see how small is the incision, and sometimes it's difficult to introduce the valve. So when you have a biological valve, it may be necessary to enlarge incision a little bit, just to increase and to allow the possibility to introduce the valve inside the chest. It's just to show you. Well, step by step, we have modified the technique. And for instance, here I have introduced the active drainage. And when you see, when we suck on the vein, we can increase the flow. And as a consequence, it was no more necessary to have 2 venous cannulation. So this is a simplification. And now, on a regular basis, I just cannulate the femoral vein, and the jugular vein is only cannulated when I have to approach the right side of the heart. Again, so another improvement has been when we have completely abandoned the incision, and now the extracorporeal circulation can be done percutaneously. For the vein here, we can control with the echo to have the vein or the artery on the first punction. So usually I put the vein on the right side and the artery on the left side, and you see how we move the cannulation. And for the vein, we had absolutely no complication. You just have to put a burst ring on the skin, and it is always efficient. For the artery, it's a little bit different. And we use the ProStar. The ProStar allows the positioning of two stitch, and then we can close the artery deep down inside the puncture, and we can have some nodes outside the skin. And with this instrument, you can introduce the node deep down to the wall of the artery. And as a consequence, today, a patient who is referred for mitral valve surgery in my institution has no more incision on the ground, and he just have an incision on the chest of 4 centimeters. And we have published this new technique of peripheral cannulation recently. If we are now speaking about the cost, you see what is the price of a standard sternotomy and the additional cost of the underclamp provided by Edwards, which is really expensive. Obviously, it is an efficient technique, but really expensive. And if you use the technique I have just presented to you, the additional cost is rather low and you can afford it. Here is the price of the ProStar if you want to have the percutaneous punction for the peripheral cannulation. Now, these are the results of my experience. There is nothing very specific. It is a result which are expected after mitral valve surgery. I have mainly repairs, and at the beginning, I used to repair only P2 prolapse, and now I am confident enough to address all kinds of repair, including the complex Barlow, including the anterior leaflet prolapse, which can be treated easily with Gore-Tex suture as my routine technique. If I see the complication, we had a low mortality rate on the repair patient, on the elective repair patient. Obviously, for the endocarditis, the mortality rate was higher. And we have some complication which are expected and as usual in all cardiac surgery. And I must confess that I have had some specific complications, the lymphocelia due to the incision on the ground, but this has completely disappeared now since we do percutaneous approach. We had 2 postoperative infarction, one due to a circumflex artery kinking, but this patient had a stent and he recovered, and the other patient had probably not enough quality of myocardial protection. I had 1 aortic grade insufficiency. This may happen through sternotomy, but we still follow this patient, and 3 phrenic nerve injury. Now, if we have a look on what we see on the literature about this topic, and there are many papers who have been published, and if we select only the most quality papers, I mean the randomized control study and the cohort studies, you see that we have 2 randomized studies, and all those papers who were a non-random cohort study, and the ISMIX group has analyzed these publications. And the mortality rate, which are summarized in this paper, shows there is no difference in minimally invasive surgery and sternotomy. And if here's 1.2 for minimally invasive surgery above more than 13,000 patients versus 1.5% for the after sternotomy. And if we split in different repair versus replacement, first time versus redo, and so on, no more difference in the 2 group of approach of the mitral valve. Now, if we look at the long term, there is no more difference. If we look at the stroke rates, this is a little bit disappointing because there were more stroke in the minimally invasive group. And if we go into details, you see that this difference was mainly due to the use of the underclamp. That is to say, if you use the Chitwood clamp and the transthoracic clamp, the technique I presented to you, there is absolutely no difference. And this is an additional reason why I should recommend not to use the underclamp. We had, again, more aortic dissection in the minimally invasive approach when they use the underclamp, only in the underclamp group. Again, a reason not to use the underclamp. And conversely, there were more phrenic nerve palsy in the minimally invasive group. On the other hand, no infection, absolutely no infection in the group of minimally invasive approach, and this is probably very important to know. The blood transfusion was less in the minimally invasive group, slightly less, but it was significant, the number of blood units transfused. And in summary, we had longer cross-clamp time. If you look at the resource and procedure-related outcomes, more cross-clamp time, more cardiopulmonary bypass time and procedure time. But on the other hand, it has no impact on the follow-up, since the ventilation time was less important in the mini-invasive group. The length of stay was less, and again, the hospital length of stay was decreased. And all this can lead us to prefer this technique even on an economic standpoint. So the recommendation of these ISMICs are rather cautious because, as you see, they just consider the minimal invasive approach as a possible alternative conventional therapy. And they highlight the fact that there are some risks associated to this new technique, but as I have tried to show you during this presentation, the risk of stroke, the risk of growing complication, all those risks can be decreased if you don't use the underclamp and if you use the technique I have tried to present to you. So I think we can manage the risk and we can increase the recommendation in favor of the minimally invasive approach. Before the conclusion, we have also to keep in mind that the mitral valve surgery there is a huge evolution, like in for the aortic valve, and where you have the TAVI procedure, and here you have many different techniques trying to implant new wings, to implant directly through the atrium without cardiopulmonary bypass, some Gore-Tex. So there are many new technologies ongoing, and the future is still questionable. So my conclusion is that minimally invasive approach with this safe technique should be the present for today. I don't know what will be the future and the place for the endovascular therapy. Probably there will be a huge place for that. We have started the MitraClip procedure in my institution with rather encouraging results. And my conviction today is that sternotomy should belong to the past, and we should prefer the minimally invasive approach as a routine practice. Thank you for your attention.